this meeting of the Health and Wellbeing Board. The meeting today is open to the public and is being webcast. We have not received any public questions, and the agenda and report for today's meeting are available on the Council's website, and a small amount are here at the front if you want a paper copy. Come and help yourself. Please can I request that mobile phones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned this afternoon, so if there is an emergency evacuation, please take instructions from the town hall staff, and the assembly point is Tudor Square. I will now ask members of the board to introduce themselves. I'll start here on my left.
Shall we start here? Okay. Yeah. Douglas Johnson, Chair of Housing.
Yeah, I'm Zach McMurray. I'm the Medical Director for Sheffield Place within the ICB and Co-Chair of the Health and Wellbeing Board.
Greg Fell, Director of Public Health and Integrated Commissioning.
Paul Ferguson, South Yorkshire Police, Neighbourhood Superintendent.
Mark Stoff, Assistant Director, Sheffield Children and Families Directorate.
Janet Kerr, Operations Director, Adult Care.
Good afternoon, I'm James Sutherland, Head of Primary and Community Mental Health Transformation, deputising for Rachel Civita.
I'm Lee Salisbury, GP in Sheffield. I also work as Clinical Lead for Health Inequalities with Sheffield ICB.
Judy Robinson, Healthwatch, Sheffield.
Hello, I'm Helen Sims. I'm the Chief Executive of Voluntary Action Sheffield.
Hi, I'm Megan Ory. I'm the Partnership Manager at SOAR Community and here as a voluntary sector representative.
Hi, I'm Kate Joseph. I'm Chief Executive of the Council.
Joanne Cooper, Democratic Services.
Thank you, everybody, and thank you to Amia, who's doing all the tech bits. So we've received a number of apologies from David Black, Lindsay Butterfield, Alexis Chappell, Mike Hunter, Emma Latimer, Yvonne Millard, Catherine Roberts-Shaw, Tony Schwartz, Rachel Civita, Rob Sykes, Meredith Teasdale. I know that some people are deputising for some of the people who've given apologies. Are there any other apologies that we're aware of? Okay, thank you. So item 2 on the agenda is declarations of interest. Are there any people who need to declare any interest? Brilliant. Public question and petitions. As I said, we haven't received any by the deadline. And so we can move on to item 4, which is the Healthwatch update, and Judy is going to take us through that.
Thank you very much, Chair. This is the update slot that I do at each of these meetings, and it really is highlighting some of the things that Healthwatch has been finding over the last couple of months since I last reported. So 4 highlights today, and the first one is taken from the pieces of unsolicited feedback we get from citizens in Sheffield. They phone up, they email, they get in touch with us. We think these are the tip of the iceberg. There are probably a lot more people with comments, and these are often people who have run out of road elsewhere, so they end up coming to Healthwatch. I'm going to pick out 2 things. And as ever, we get criticism and positive comments, and I always want to balance those 2. So just taking an aspect of GP services, we get a lot of comments about helpful staff who are really positive and supportive. But one thing stands out, and that's the online booking systems in some GP practices. Even when people say we can't use them, those systems don't change. And that means that people go elsewhere and probably use other services inappropriately. I think that could be changed relatively easily, but it hasn't, and we keep reporting on that. And then the second item I want to pick out from the comments we've had is one that comes up time and again, and it's about mental health. And if you've seen the December, January 24 report, there's a lot of detail there, and I'm going to pick out a few things. A lot of our feedback is about mental health services. So pick out this one, which is about the lack of flexibility for people who find going to clinical settings are really quite unsettling. They really can't cope with it. And sometimes, if they don't turn up, they're removed from waiting lists. They're called, because they missed an appointment, because they couldn't quite face it. And they're seen not to be, quote, engaging. And that's a common problem. So people in crisis are not getting the support they need. And then another one I think is about people falling between programs. There's an ending of a Changing Futures program. Quite a number of people don't know where their support is going to come from. And they're falling between different services. And in all of that, there are words like eligibility criteria, referrals, engaging. And I always think when I hear those sorts of words, they're too often about services that are focused on the system, but not on the person. And that is quite worrying. And then the third one around mental health is about people trying to navigate a quite complex system and finding that they can't get the support for a relative or a friend who might be in crisis. And they end up then going to A&E or phoning up or going to the single point of access, which doesn't quite work, phoning up the ambulance service. So not getting it right the first time means you push people on, and we know that it's still happening. And the SPA is a difficulty that we've been reporting on for some time. So a sense of a system not communicating between systems and not communicating with patients and carers in appropriate and timely and in different ways. People need different sort of communication. This report goes to the services mentioned before it's published. And you see on the back of it their responses, which I think are beginning to come forward a little bit more than they perhaps were. So just as an example, we talked a few months ago about transport and hospitals. And STH have come back to us on what they're doing around that, particularly public transport. So we don't want to just shout into nothing. We want to get a response. I think that is happening a little bit more. So if you want to see what people are saying, this is a report to look at. The second highlight is a piece of work we did, something called Speak Up, which is a small grants programme that we give to community organisations for them to say what health issues are important to them. And this particular one is with the Salic Youth Project in Burngreave, mainly with youngsters from a Pakistani Muslim background, talking about their access to healthcare. And two things particularly came out of that. One was it also related to GP appointments, that it doesn't quite fit with schools and colleges, quite hard to get there because of public transport. So a bit of a misfit. And then the other one, which is again not new, is about young people having to interpret for their older relatives because there aren't interpreters booked. And for reasons that I won't go into, it's obvious. That doesn't always work. It's probably not appropriate. So some of those things that probably could be tweaked relatively easily would make a difference. Some really positive comments as well. And then the third one I want to pick up is, I think, a really lovely project we did with Children's Mental Health Week in February. And we did a project around pictures and painting. And the theme was, Why My Voice Matters. And I've got some copies here, lots of really lovely pictures that kids did about what was important to them. There's a lovely one here of swimming, which is, yeah, you can have a look at that. I'll give you some reports. And not surprisingly, but worth saying, children value family and friends, hobbies, nature and outdoors. And we heard that when we had the mental health report, how important that is for people. Their cultural identities and their pets. And I just want to read out a quote, which I really liked. Lots of children drew or wrote about their family, especially their parents and some siblings. We learned a lot about children's pets too, which featured nearly as often as human family members. So if you're a parent, don't forget the guinea pig is really important to your child. So some really interesting things. And then there was a little art competition and we had some great entries to that. But more seriously, all of that underlines how supporting families helps children to stay happy and healthy. Then I want to lastly draw attention to a report which I haven't brought, which was commissioned about people's experience of palliative and end-of-life care. It was commissioned by the ICB as part of their developing a strategy on the same subject. And they wanted to make sure experience was at the heart of that strategy. And quite a lengthy report on that if you want to look at it. I just want to underline, though, that all 4 of those reports, one from direct experience that people come to us with, from people, the Speak Up commissioned report to community, work that comes through a commission, and Healthwatch's own initiatives. They're all ways of trying to find out what the people, the citizens of Sheffield, think about health and social care and what matters to them. And our job at Healthwatch is to try and put that into the health and social care system. So do if you want copies of the report, they're all on the website. Do ask me and I'll hand them out, but I'm happy to take questions. Thank you.
Are there any questions for Judy? Greg?
More of an observation, thanks Judy. It's just specifically on the changing futures thing. Broadly thought of as a pretty good programme actually, and has delivered what we expected. We all know there's a significant number of cliff edges associated with the end of the end of the initial funding period. We're trying to resolve those. I think they've been resolved, but I can't commit to that right now. But I think they have. I don't know how well we've communicated that with the end users, however, so there's a piece of work for us all to do there. And just observation on the sort of the person-centred versus what the machine says. My sense is that sort of the level of professional practice, professional to client, service user, patient, we're pretty person-centred actually. Our failing, and it is our failing, is the machine. The machine and the systems and the operation haven't quite caught up with the way we want our professionals to act. That's our job to sort. That's just my observation, and I may be wrong on that, but that's a pretty consistent observation here across lots of spaces.
I think a lot of this comes out of communicating in timely ways, and if that was done better, a lot of those problems wouldn't be around.
James.
Thanks for your report, Judy. Just wanted to come back, hopefully, with some positive sort of early shoots of spring on the mental health. I recognise everything that you've said there in terms of sometimes the lack of flex. You may be aware that there is a community mental health transformation programme that's currently taking place in Sheffield. Within that, we're moving care, support, treatment closer to where people live into those local communities, collaborating with our primary care GP colleagues, but also looking wider as to how can we actually have mental health staff potentially based with housing staff within the local authority, where we've had really positive conversations. Why can't people be seen in voluntary sector organisations? Similarly, and actually having the flexibility for some people, do they want face-to-face, do they want virtual or telephone? And actually, that needs to be person-centred to be the choice that best suits that individual. Completely agree in terms of navigation of a complex system. We're working up new information and pathways to try to make that simpler. What we're also doing is moving a system away from one that sometimes is predicated on the words that you said: referrals, discharge, engaging, back to square one, pass from pillar to post, and actually people feeling a bit like the human pinball bouncing around the machine that is mental health. We're moving away from that by the end of April. Single point of access will cease to exist in its current format, with actually non-urgent and routine needs being seen in local communities. If you're referred to one team, they're not allowed to send a letter back to someone saying, no, go and see this team over here. They'll be taken to weekly huddles so that there are different parts of the mental health system talking to each other and we're actually stopped. We've already suspended a number of those letters that were previously sent out. So I'd be delighted to pick up a conversation with you and colleagues on offline. I know your colleague Laura Crook's been wonderful, and I'd like to acknowledge her for being part of our transformation board as well, giving continual rich insights from our wonderful Healthwatch colleagues.
Thank you. If there are no further questions, I will move on to item 5, which is the Better Care Fund update. And I think Catherine is deputising. Thank you.
Hello, I'm Catherine Bunton. I'm the Assistant Director for Commissioning and Partnerships in Adult Care and Wellbeing. I'm here, standing in for Alexis and Martin today, so I'll answer the questions to the best of my ability. I think Board are presented the report for information and asked to note the submission of Q3 performance, which was submitted to NHS England in February following a members' briefing. I would particularly suggest that the board notes the good practice coming out of the partnership work around falls, and also note that there's a deep dive into avoidable admissions where we would like our performance to improve, that's due to come to the next board.
Any questions? Lee.
Thank you. I was interested when it said about the deep dive into avoidable admissions. Do we know particularly what's being looked at or interrogated with that? What sort of issues are we hoping to understand? Oh,
sorry. The deep dive came through a briefing that the chairs had, wasn't it? And we asked for data to see who goes in terms of unexpected, avoidable admissions. And I think it links in very well with what Judy was saying as well. People can't get to the GP or can't get any other services. So we are going to, we've asked at before the next meeting to have a report on with data so that we get a better picture, and then we can ask for, to remedy the situation if possible. Also to see which areas people tend to come from, just to see where our weak points are. So we had a really lengthy discussion about avoidable admission. Zach.
Yeah, Lee, I think it's linked to the thing about that we talk about the reason for an admission. So I think the perception from some of the national stuff is these patients are admitted with these conditions, therefore these conditions are not well managed in the community. Whereas I think the perception that a lot of us have got that work in the community is that quite often patients are admitted through lack of well-being, lack of support, pitching up at A&E, don't speak English, no records available. It's the issue about, patients from very deprived areas at 55 look like patients, frailty-wise, from less deprived areas that might be 75. So how much does the clinical threshold adjust and end up admitting? So I guess what we're kind of getting at is, are these patients admitted because of medical reason, or because you've got to put a diagnosis on the computer? Is it the medical reason that's picked out as the reason for effectively a lack of coping, lack of well-being, that sort of admission, which is quite critical, because actually it could take you in the totally wrong direction if you're not careful.
So just to come up, I think that's sort of what I was getting at really, because why people end up in hospital is often quite complex, isn't it? And if you don't understand the background to that, so we could just get the demographics of going, oh right, it's these people of this age who live in this address, of this race, but actually it's more the stuff that Zach's talking about, I think, and how did they end up there?
I think that's why we asked for a deep dive.
Thank you.
For exactly that reason. Greg.
Catherine, thanks, and thanks to Martin and team. As ever, it's a really, really good and comprehensive report. We hit the target, just about, give or take a bit. That's no mean feat. It doesn't happen by accident. It happens because a lot of people work pretty hard on that. And that has an impact, difficult to measure though that might be. Two thoughts. One, falls. I have a sort of a particular bee in my bonnet about specialist services versus generalist. You know, everyone says we need a specialist fall service. Actually, the business end of this happens in general practice, community care settings, and we neglect strength and balance in middle age into early old age at our peril. We continually do that, bluntly, sweating more and lifting some more stuff. So that, for me, has to be in the falls mix. And then on the avoidable admissions, I think I saw Zach's, we missed the target by a bit. Again, the business end of that, yes, there's some coding and system pressure that impacts on that. But the business end of that is primary and community care, and the system records the secondary care thing, and this isn't a sort of an anti-secondary care point, but the business end of achieving that requires good quality primary and secondary care, primary and community care and social care, which we have, but we all know it's under-resourced. So there's sort of the resourcing point is the business end. So in our narrative to NHS England, I hope we're continually bluntly banging on about that, because it does matter, and that's the point of NHS reform, has been for the past 4 decades. But thank you all the same.
Thank you. I just wanted to add something about, I wanted to ask a question, or just put like a little bookmark about city-wide care alarms, because I know that there is quite a lot of work going on from our side in council in strengthening that. But also I wonder how people are referred into that, because from the report it says people can, you know, that wish to or want to, but I wonder whether we can do more active, because fall prevention is one of the main causes of people being taken to hospital, and I wonder whether we can do some more proactive kind of referring of people to that service.
Shall I come in there, Angela, just to say that whenever we're doing an assessment on someone, or working with someone, or even working with people who end up not having assessment and don't need a support plan, we would always talk to them about citywide alarms. So I guess people either approach us as private individuals, but it would be something constantly that you know, social workers and social care practitioners would be raising with people. We would really push that.
I was using the royal we, I meant us as a partnership.
Oh, as a
so I was more
right,
wondering
okay.
about GPs referring, and, you know,
how aware
other
of people.
voluntary sector organisation just raising awareness of the service, so that people could then opt in if they wish to, or if they need to. Thank you. Thank you so much, Catherine, for stepping in. It's a funny week to have a meeting, I suppose, just before a bank holiday. Thank you. So we're moving on to item 6, health protection. Ruth is here.
This is the bit where I'm exceptionally pleased Ruth has turned up, because it saves me doing the talking.
Thank you, Ruth.
Afternoon, everybody. I'm here to give a twice yearly update on health protection in the city, and I've chosen today to particularly talk in detail about a measles outbreak that we had at the end of last year, and some learning that we've got from that, which I think highlights a lot of the issues that we've been talking about in previous times when I've come to this. Oh, thank you. When I've come to this committee, and I should have introduced myself. That's what prompts me to say that I'm in Greg's team. I'm a consultant in public health, and I lead on infectious diseases and employment and health, which is actually the next item. Our colleagues in UK Health Security Agency who manage infectious diseases have very helpfully conducted a debrief on this outbreak with some key learning for us, and I wanted to talk a bit about that, but I also particularly wanted to talk about the underlying reasons for having an outbreak in the first place, which is an insufficient uptake of MMR vaccination in different communities in our city. So as the board also probably is aware, measles is a highly infectious disease, but it is preventable through vaccination, and it can have serious health implications for children. But as well as that, it can also cause massive disruption to health services by having to identify people who've been contacts or staff being off work,
and also has big implications for school attendance if children have to be off. So we really want to avoid measles outbreaks. And people might be aware from seeing in the news that we've got other parts of the country who've got some really difficult and substantial ongoing outbreaks of measles. So it's really pertinent that we talk about it. So in November we had an outbreak linked to a nursery as part of a school in North Sheffield, and Greg, as Director of Public Health, activated the mass treatment and vaccination plan. That was really successful in that vaccination was delivered in that school a week later to over 40 children who accepted vaccination at that point, and they hadn't previously. So that's really interesting to see that they accepted it then when they'd previously been offered it. And it was great testament to the hard work of our colleagues in primary care and the Children's Hospital school age immunisation team and a local school who had great engagement with their schools and families, that they were able to get that level of agreement to people being vaccinated. Some of those things were the things that came out of the debrief, but I think one of the really important things for us to consider is about our underlying vaccination uptake with measles, and it's still quite a long way from the World Health Organization level, which is set at 95%. So children are offered 2 doses of a measles-containing vaccine, MMR, and the measures of how we're doing are about how many children have had 1 dose by the time they get to 2, and then how many have had both doses by the time they get to 5. And 1 dose will be good to prevent an outbreak of measles spreading, but 2 doses is going to be good to protect children for their whole lives. So considering we're trying to get to 95%, last year the percentage of children in Sheffield who'd had 2 doses of measles by age 5 was actually only 85.2%. It did improve in the last quarter to 86%, but you can we're still quite far away from that, and that is really spread quite differently across the city in terms of uptake, and it is linked, as these things often are, to socioeconomic deprivation. Now, our colleagues in NHS England do commission vaccination programmes through primary care and through school-aged immunisation team in the Children's Hospital, and there is quite a lot of additional work going on in terms of additional offers in the community, work in primary care, additional offer in secondary care. But I think we have to acknowledge that this is a really tough job, trying to increase vaccination. We've got lots of colleagues who've been at this for a long time. So while I wanted to recommend to the board that we thank partners for responding to the measles outbreak, I also wanted us to continue to seek all opportunities to make vaccination easy to access and promoted through trusted community voices. I think one of the things that was really striking about the success of vaccination delivery in the school was the combination of a local GP and the school-age team answering parents' questions, and parents feeling then that they were in a position to be able to take up the offer of vaccination, and that having it in a school setting was a place where they trusted, as well as obviously the trusting primary care. So those were my recommendations that I wanted to make today, but I'm happy also to answer questions and comments.
Can I ask the first question?
Of course.
Whilst we thank, I know because obviously I've been kind of kept abreast with the development, and I know that people work really, really hard, and they always work really, really hard on outbreaks of whatever nature. As that approach has really worked, could we proactively use that approach? Like where we go into the school, we work school, and I'm sure we do it already, but can we just, because if that has worked, it's like a learning point for us from this, isn't it? So
yeah, and I think that's a really interesting question. Thank you for that. I think there's a whole range of different things that are happening in Sheffield, but it's interesting to hear about approaches that are being taken in other cities as well. So, for example, from a conversation I had with my colleague in Leeds, they are going into schools to offer catch-up of measles vaccination, and that's something that we'd obviously really want NHS England to be talking to our colleagues in the Children's Hospital about whether that is possible to do in Sheffield, because I think that what we've seen from the learning from our outbreak is that some families will say yes when it's offered in a school setting, even though it's been constantly offered in GP practices as well.
Lee.
Thank you. Thanks, Ruth.
Welcome.
That's good news.
Yeah.
And we can't walk past that, can we,
No.
actually?
It could have been
looked very
awful.
different.
It could have been really awful.
So
yeah.
I'm sort of sitting here thinking, how shall I phrase this? I won't rehearse what I often say about how the system has chosen to fund immunisations makes it harder. I have just rehearsed it, haven't I? Makes it harder to hit the targets.
Yeah.
But in spite of that, I think a year ago or more, we agreed as a Sheffield ICB to fund, to recognise that deficit in funding and maybe to look at how we could use that funding to do the very things that you're talking about in terms of how do we do things differently. And there is quite a lot of work that's going on, particularly in the north of Sheffield where, as you say, the average immunisation rate looks like one thing. In localised areas it looks very different, and the risk is much higher. And the risk isn't just about children not being immunised, although that's obviously the number one. It's the way that people have to live, the multi-generational families. There's lots of people living in very crowded conditions, makes it much easier for infectious disease to be transmitted. So it's an interesting, I think actually the council funded some work with Vale Centre, particularly looking at the Roma community, about actually how will that, it's an interesting report to read, because some people say actually we really want to hear this information from a GP, trusted person in authority. Other people go, actually, I'm not quite sure I trust authority, I want to hear it from my neighbour. And so it's a complex picture, isn't it? But I think the end point of what I'm trying to say is we're really pleased, particularly in the north of Sheffield, that there is funding available and there is a lot of work now that is happening to look at how we could try and improve those immunisation rates in what's quite a complex context.
And I think if I can, I'd like to particularly mention the school. You know, their job is education, it's not delivering healthcare, and their relationship with their families and their community was absolutely central to getting that trust. So I completely agree with you about the trusted voice of GPs, but the school also was a really trusted source, and we were working really hard to support the school to say, we know this isn't your day job is to deliver education to children, but thank you for caring about your families and communities and knowing that your trusted voice can encourage them to come and be vaccinated. So I know that colleagues, Mark, so I just wanted to pass that particularly back on to, our work that we do with schools. That was really valuable, and that community engagement can't be underestimated really, because we also know that colleagues in other parts of the country who've had measles outbreaks have put vaccination sessions on and people haven't come because they need to trust that they can have that vaccination and that they can ask their genuine questions. People have got a lot of genuine questions that they want answering about vaccination.
Sorry, just really quickly, I think that's such an important point, feeding back to what part of the Healthwatch report is. It's not one organisation going, that's not my counter.
Yeah.
It's everybody working together to do the right thing for the people in front of them that's made the difference. Right.
So thanks, Ruth, for orchestrating the response to that outbreak. It's worth us noting that, and I underscore the thanks to the school, primary care colleagues, UK Health Security Agency, Children's Hospital, and many, many others. The system in this space isn't one actor, it's many actors, and it works because of coordinated effort, sometimes goodwill as well. This is the thing that makes me twitch most, an uncontrolled outbreak. We've seen from other parts of the country how disruptive they are to the economy, to the healthcare system, to families, to anyone you care to mention. We know what we need to do and are doing with regard to the underlying vaccination coverage for MMR in particular, and credits to the NHS, to the ICB place team for doing what they did a year ago. I'd be fascinated to see the impact in terms of numbers if you've either done that, I don't know. I would sort of probably repeat our ask of NHS England of about 18 months ago. Lee's point, the system has chosen to fund vaccination in this way. It's a well-trod national issue. We get what we pay for, ultimately. So I might dust off that letter and probably resend it, because I don't think the Health and Wellbeing Board chairs have had a response. And I would underscore, Councillor Argento, you picked off this point. I think I would ask the School Age Immunisation Service to do opportunistic vaccinations in schools with the lowest uptake, or schools in areas with the lowest uptake, because it will almost certainly pay off.
Yeah, I totally agree, and yes, let's resend the letter. And also, I know the school's job is education, the health impacts on education, because if kids are off work, then they miss school, and you know, you've got the attendance, you've got the attainments, so we can't really separate health from anything. So I think it's brilliant that the school was so with it, you know, and knew the community so well, and I'm sure that is the case all over the city. So yeah, opportunistic vaccination, let's see if we can do that. I've got Zach coming in. Ruth, do you want to come back?
Just wanted to say that Greg did write to the head teacher to say thank you, because we recognise that they did go above and beyond, really.
Yeah, I was just, again, going to personally say thank you. I mean, it looked very scary at one point, and everybody did pull together. I think it's a really good example of a system pulling together to do the right thing. Again, I want to reiterate my frustration with a system that actually stops you doing the right thing. And, you know, the example that Lee gave, and we're almost getting to the point that, I think this is a danger, that we just accept it. So, I mean, Judy talked about the online booking, that there's massive pressure from the system above to move to this. This is supposed to be the saviour of general practice. That's not because it stops patients being able to book in. I mean, so it does need a different approach nationally to some of this. The figure I saw recently, which is really quite stark, and believe me, I mean, in deprived areas, and particularly with different cultural groupings within your population, it is really hard to deliver general practice, particularly the sort of preventative stuff that we talk about. The figure I saw was that the way that the national contract is set at the moment around rewards, financial rewards for hitting targets, most of the targets being totally impossible to reach within most deprived areas, mean that the 20% of practices in the most deprived parts of the country get 14% less income than the practices in the least deprived. It is bonkers. And it is really difficult, because you say that and everybody says, oh yes, the system. At what point do we say, let's change the system? Because actually it's harming people. So again, it's anything we can do, whether it's worth having another try with another letter, just to try and get the change. The other thing we came up again, which again is hugely frustrating, is we reached a point that it was clear that you had to probably vaccinate a lot of practice staff, because either they couldn't prove they'd had an MMR, which was quite MMR injection, which actually was most the case, or else they hadn't had one. And the obvious solution to that is GPs vaccinate their own staff. They're on the premises, you can do it really quickly. It was almost as if the system took great pleasure in saying, no, you can't do that. And eventually we managed to get that concession, but it was only for a period up until the end of March. So you can give the first vaccination, but you can't give the second one. It does really feel we're up against a system that is absolutely insane. And I think we do need to keep just reiterating that is not acceptable.
Thank you. So can we have as an action, Dan, that we are revisiting a letter? Are people happy with that? We'll see if it works. So are there any other comments? Yeah. Okay. Yeah, it's about the one that we did 18 months ago. Sorry. So as far as this report is concerned, we are asked to note the report about the outbreak and thank partners and individuals with the Sheffield system who responded to the crisis. Are people happy with that? And the letter. Yeah. Brilliant. Greg.
Not MMR related, but one of the purposes of this 6 months is to give board members an assurance about other aspects of health protection. I suppose, just to note, it's a reasonably well-functioning, well-oiled machine, as the response to the outbreak demonstrated. When there's a crisis, we pull together and we address these things in peacetime. I'll circulate to board members a link to the relevant health protection outcomes, so you can get a sense in one space how well we do. One thing I would just draw to the attention of board members, it's a shame Dr. Black's not here, and he knows this, one of the areas which is under particular pressure is STI rates. We've mentioned it here before. STI rates are going, they may have stabilised now, but they're much, much, much higher than they were 2 to 3 years ago. We're revisiting our strategy with all of the relevant partners, but just worth noting that. It's another area that does make me twitch.
Thank you. So we're moving on to item 7. We're a bit ahead of schedule.
Laura is on her way.
Shall we have a break now?
A very quick check and see if she's waiting to come up.
Yeah, we can have a break now. Should we do that? Oh, she's here. Brilliant. Thank you, Laura. Sorry, it's just I'm so efficient as a chair that we're early.
And it's me again as well, so I might switch chairs just so that I feel like I'm doing a slightly different item.
Okay, so item 7 on the agenda is employment and health. So presenting are Laura Hayfield and Ruth Granger. Thank you.
So, hello everybody. So, I'm still Ruth Granger, but I'm now here to talk about employment and health. And this is my colleague Laura. Do you want to introduce yourself, Laura?
Yes, hi, I'm Laura Hayfield. I'm Head of Employment Skills and Economy.
And we're going to be doing a presentation which we hope is going to be appearing on the screen in 2 minutes. So, we'll just talk amongst ourselves.
Sorry, we have allocated quite a long discussion today, so we've got 40 minutes officially for this one, so feel free to ask lots of questions, and then we're going to have a break. Oh, and the presentation is ready. There you go.
Great. So me and Laura are going to take it in turns to talk about employment and health and talk about the benefits of good work and the work of this board and as a board in itself, but also the work of the board as partner organisations in contributing to people having good work and getting the benefits from keeping and having a job. So employment and health is important for individuals and families, but also more broadly, it's important to have a healthy workforce for the economy and for the city as a whole. Thank you. Can I do the slides myself, or do I have to say next slide? I'll wave at you. Oh, I can do it myself. How exciting. Although being able to say next slide is a kind of ambition, isn't it, really? No, it's fine. You can just do it for me if you want. Lovely. So what we're going to cover in this presentation today, I'm going to talk about employment as a key wider determinant of health. We're going to talk about good work being good for health, and important in this is a definition of what good work is and what good work isn't. We're going to talk about getting a job, which has often been a priority, but also it's so important to support people to retain their job, particularly people with health conditions. And as a substantial proportion of the population who are out of work or who lose their job have a health condition. We're also going to talk, as I mentioned a minute ago, about the role of the Health Wellbeing Board as a board and as major employers. And then we're going to talk briefly about some of the programmes that we have in place to support people, particularly people with health conditions, to get a job and keep their job. Thank you. So just to say, this is a helpful picture which shows the importance of health and work for some of the wider issues that we have in the city. And in healthy individual work, contributes to a healthy workforce, which does contribute to business competitiveness and contributes to our economic development and prosperity in the city, which is one of our key city goals, which I'll talk about later on, is about developing that in the city. Thank you. And I just wanted to start with the absolute basics, which is that unemployment is bad for health. Unemployed people are more likely to die, and we've known this for a long time. This is actually a graph from 1981, so it's a long time ago, showing people who are unemployed are more likely to die in a year from every different social class than people who are employed. And this was also quoted in Marmot to show the real importance of employment as a wider determinant of healthy life expectancy and life expectancy. Thank you. So I've already mentioned quite a few times that we're talking about good work, and good work improves health and well-being. A massive part of that is being a source of money. Now, that isn't the only reason why good work is important, but if you haven't got enough money, then work as a source of money is really important. And you can see here, this is research from the Joseph Rowntree Foundation about the proportion of adults living in households who are living in poverty, and only 5% of adults in households where all adults are full-time employed are living in poverty. Now, that's obviously an issue in itself, that we've got people who are working in poverty, but actually half of adults in workless families are living in poverty. So having a job, really important factor for poverty, a really important factor for health, life expectancy and healthy life expectancy. But we would be the first to say that also work is really important for wider aspects of people's health, for that social support that you get, from that sense of well-being you get from having a purpose and a fulfilling occupation. And also, because we're going to come on in a minute to talk about health conditions and work, good work also really important for recovery as well as preventing ill health, particularly for people with mental health conditions where it's been really well established that having a mental health condition but being able to work really aids your recovery from your mental health condition, or being able to maintain good health with a mental health condition. Thank you. So I thought I'd just put this definition up here, which is from the Trades Unions Congress, about what a good job is. And when you read this, it actually looks pretty basic, because it's about being paid fairly, treated decently, and the opportunity to progress. But we know a lot of people in the city don't have a good job necessarily, and I think it's helpful for us to reflect on whether our organisations are good employers as anchor organisations in the city, and whether we successfully recruit and retrain staff, including those who've actually already got a health condition. I have a particular thing about bananas and yoga. You can't tick the box that you've provided bananas and yoga but provide 0 hours contracts and discriminate against people in the workplace. Bananas have got a place, obviously I would say that, wouldn't I, working in public health, but only in the context where you're actually providing good work in terms of your terms and conditions in your job design for people. And really important for the opportunity to progress and get on in life are employers supporting people to train and progress. Thank you. So you might not be able to see the caption for this, but I just wanted to talk about the geography of unemployment, and this map probably looks like maps that you see every single time at the Health and Wellbeing Board, to be honest, because it's about a map of socioeconomic deprivation. But this is about children who are living in out-of-work families. And I'm wanting to put that to make the point that although work is really important for an individual, it's really important for a family as well, in terms of that income, in terms of that social norm, that when you grow up, you're going to get a job, you're going to be able to have that ambition and that sense of wanting to achieve that. So we know that people who can get a job, it's going to impact their whole family and the next generation as well as them. And that's related to this next slide, which is about the proportion of children in living in the UK who live in households where no adults are working. It's 11% in the UK, but it's close to 1 in 5 in Sheffield, and that's going to impact the now and the future. Thank you. So I thought, as we've established that work is really important for health, we'd talk about why people aren't in work. And there are two main groups of people, one of which is increasing, one of which is decreasing. So those out of work because they have ill health is actually increasing, and that's been increasing since the pandemic. And Laura and I have been talking about how mental health is a big component of that. It used to be substantially that it was musculoskeletal conditions and mental health, but mental health is the one that's increasing. And those who are looking after their family or home is a reason why people aren't in work, but that's actually decreasing. I think it's really interesting to know that a lot of people who aren't working, who have ill health, actually want to work, and that actually is even more so in Sheffield. We've got a higher proportion of people in Sheffield who are economically inactive who want to work, and that's because they recognise the benefits of working for themselves and for their families and for their income. So I thought maybe it'd be helpful to know a little bit more about what are the health conditions of those people who are underrepresented in the workplace. And the sort of top line figure is those with or without a long-term health condition, there's a 10% gap in employment. But there's actually a massive gap for those who need support from secondary mental health services. And that's why we see that, for example, in talking therapies, they now have employment advisors linked to talking therapies to support that in mental health services. And there's also work with people who have more serious mental health problems, also having employment support because of what we talked about mental health and work being helpful to recover from mental health issues. And then we do have subgroups as well. And I know that the board previously received an update on the autism strategy, and we see that while 52% of disabled people have work compared to 81% of non-disabled, actually people who are autistic have got even lower levels of employment. And that's not only an implication for them, but it's also about the skills that employers are missing out on by not employing people who've got those very particular skills that they could bring to their business or or to the organisation that they could work for. Thank you. So I just wanted to come briefly onto governance. Obviously, we're here at the Health and Wellbeing Board. That's a key part of this health and work space. But we've also got the Sheffield Employment and Skills Advisory Board. And I just wanted to mention a subgroup of that, which is called the Local Integration Board. There's one of those in all of the South Yorkshire areas under the Mayoral Combined Authority, and that's where we come together with providers, for example from the community and voluntary sector, to talk about how we deliver that employment and health support in the city, and that ranges from, like I say, big partners like Department of Work and Pensions to small but really significant partners in the voluntary and community sector. And at our meeting last week of the Employment and Skills Board, we heard about the really valuable role of the voluntary sector in supporting a whole range of needs that people need to be addressed before they can get into work. There's obviously often a lot of complex issues that people come with that the community and voluntary sector are doing a particularly great job in addressing for people. Thank you. Next slide. So as I mentioned before, this links to the city goals. This also links to the health and wellbeing strategy. So that's an area of overlap in some of our strategic direction that we're trying to take. And then we're going to go on to Laura now, who's going to do some slides about the skills strategy and some of the work we're doing locally.
Thanks, Ruth. So, yeah, there's a project underway now to have an employment and skills strategy for Sheffield. There hasn't been one for many years. And that's a real opportunity for us to sort of draw together what is quite a complex field with lots and lots of different partners in Sheffield involved. And we need to make, have a more cohesive approach, if you like. So it'll deliver a long-term vision for the city, but really importantly, it'll provide a roadmap. So we've got, as Ruth said, the city goals, we've got the council plan, but we actually need some meat on the bones through the skills strategy to actually come up with priorities and how we're going to tackle them as a system. There are 10 themes that have been put into the Commission for the Employment and Skills Strategy, and 3 of them, Ruth and I felt, were particularly relevant for this board, around increasing economic activity, so the flip side of addressing economic inactivity, which are those people who don't work but also don't claim benefits. Providing targeted or specialist support, so Ruth was just talking about people with autism, and actually some specialised support for that group and for other groups not in work because of health conditions need tailored support. And supporting employers to provide inclusive workplaces. So we know that an awful lot of employers don't necessarily have the infrastructure to be able to support people to stay and work. Thanks. So, how do we as board members of the Health and Wellbeing Board link to the agenda? So in 4 key ways. So obviously as commissioners of work and health programmes we can include components of good work into contracts that we let. As employers, often of quite large organisations who employ quite a significant amount of Sheffield residents, so that we can be leaders in good practices for supporting our employees. As referrers, so particularly GPs and other people related to the health service can refer to employment support projects as part of a menu of things that can address ill health. And then as providers of health services, because obviously people on waiting lists who aren't getting seen, and if that's then preventing them from working, then that's a consideration. Thanks. So, this is really a list of the people who are on that board that Ruth mentioned, the Local Integration Board, and you can see that it's a mixture of commissioners and providers. So Ruth mentioned that we've got a really active, vibrant and committed voluntary and community sector within Sheffield, which really helps to provide some of this hyper-local support that's required for people. But you can see it's a little bit messy in that there's about 4 different commissioners, DWP, SIMCA, the council and the ICB, and then because the commissioning isn't necessarily joined up, that then causes problems for actually frontline delivery being joined up. The other thing that we really struggle with is that the funding is all very piecemeal. So if you look down that right-hand side there, pretty much everything drops off a cliff at the end of March 25. So we're constantly having to reinvent the wheel, but then that isn't helpful in, for instance, supporting the voluntary and community sector to provide support, because they are long-term organisations wanting to offer long-term commitment to their clients. And then there's a range of mainstream services as well. So DWP, the Job Centre, provide universal services, and then these are added to with other projects, and we mentioned here Working Win, which is delivered by the Shaw Trust in Sheffield now. We have other services like talking therapies, as Ruth mentioned, and then we have supported employment programmes as well. So they tend to be programmes that provide ongoing support, particularly to this client group, in that it's not just about getting into work, but it's about supporting the continuation of work and sort of drawing that support away on a slower basis. But as Ruth's put on this slide here, it's complex, and we really do need to improve the coordination of the frontline services. Thank you. And then the other point is job retention. So I just mentioned about staying in work, and there's some quite scary stats up there about the amount of time that is lost, as in for people being able to do their jobs because of various health conditions. And there's a nod on this slide to the mental health issues as well, which, as Ruth says, is a really rising issue for people retaining work. Thanks. Okay, so there are a variety of services as well to support people to stay in work, and we just thought it'd be helpful to run over those. So there's obviously the universal health services, GPs, MSK teams. I'm not going to try and say that word, Ruth. There's good employment practices, so that are required by employers legally to provide. There's occupational health services, and then we've mentioned then the contracts that Ruth's team procures, which is through Sheffield Occupational Health Advisory Service, that can support people to stay in work, and that's a free service to businesses. So, what further provision do we want to see locally? Well, there's the Work Well partnership bid. So this is a fund that's been put out nationally that, off the back of Working Win, Simca have applied to in partnership and support, for instance, with the local integration boards. And it's going to try and help people who are a little bit closer to the labour market than some others. And quite a bit of the provision in the city does this, so it's really important, as I'm here saying we want to integrate things locally, that we're not just parachuting a shiny new thing to come and work in competition with the stuff that exists on the ground. So Ruth and I and partners are working really hard to see how we can augment and use the good practice that exists using this funding, and we expect to hear in April whether that bid has been successful, and working with Simca to ensure that they can support that hyper-local provision that I've been talking about is so worthwhile. Thanks. And I'm not going to read through the case studies because they're too far away, and you've all had them in your packs, but there's two case studies here and two on the next slide as well, and they show different successes that different providers of the services I've talked about have been able to achieve, and give good examples from sort of 4 different support services that I've mentioned. So yeah, you can flip past that one as well. Okay, so we've got a number of questions for the board, and on the next slide I think we've got a number of recommendations as well. So I don't know, did you want me to read through those, or are we handing back to you, Angela?
Thank you so much for that presentation, and it was very interesting to read through the report. Actually, I made quite a few notes myself on that. So, are there any comments, questions, Greg?
Thanks both. A really comprehensive overview of a complicated ecosystem, which is fiddly and difficult. I think you did a great job. To the three comments, more questions. On the increasing people who are not in work because of illness, there's a difficult, largely unanswerable question, nobody's prepared to answer it, on the do we differentially prioritise the working age population to treat them, to enable them to get back to work on account of working age, access to employment in itself a determinant of health, over and above clinical need, the enshrined principle of the NHS. Nobody anywhere is prepared to answer that question, but it's a really difficult one. It's one of the root causes of this. Second point, I was struck by the complicated governance slide. Complicated commissioning, not joined up, piecemeal funding. Do we do enough on stitching together the complexity? Have we got enough knitters, basically? And have we got the right single focal point? Maybe too complicated. And third question, I was struck by the Working Well partnership slide. We all hope we're successful. I'd just recommend that we sort of try and agree some default design principles. One, I'd say, reflects the complicated ecosystem, which one single actor is just not going to work. Secondly, especially the role of the voluntary community sector in this space, which is massively underplayed, but really matters. And thirdly, must be place-based as a minimum, preferably beneath, if that's the right word, place-based, but certainly must be place-based, because the default organisation will look different in the 4 places in South Yorkshire. And I'll write that down, but that would be what I'd recommend.
I'll have a try at some of those, and then Laura can have a try. I think in relation to prioritising people of working age who might be on a waiting list, I think that's possibly sort of more of a national policy decision, but I think there is something about a recognition by health services of the risk to people losing their jobs while they're waiting, and is there any support that they could be given while they're on a waiting list, for example? So can they be referred for support to help them keep their job? One of the things that Laura and I and the Local Integration Board have reflected on quite a lot is that employers, particularly because we've got so many small employers in Sheffield, actually maybe don't fully understand what reasonable adjustments are, how they can do that, what support they can get for their employees. And actually that's no good for anybody, because then those employees don't get the support they need, and the employers are thinking, oh dear, what am I going to do with this person who's waiting 3 months for an operation and can't do various tasks in the meantime? So one of the things that we've particularly wanted to talk about in the Workwell partnership bid is that a big component should be employer support. And we're also acknowledging as a group that even if we don't get that money, we still need to have a priority on employer support, because some of the feedback that we get from organisations who are working with employees is that quite a lot of their work needs to be advocating for the employees with the employer, because the employer doesn't realise actually what they need to do in law to support that person to keep their job. So there is the support for the individual, but there's the support for employers. I think I maybe drifted off one of Greg's questions there, but I think that's really relevant. In relation to the right focal point, it's quite hard to have a right focal point, and I think one of the reasons for establishing the LIB is to bring all those providers together. They've already had some really useful conversations about, oh, you accept referrals, oh, you do that, oh, and what we're trying to promote is that understanding that there is a range of options out there, and that people need to be signposted to the right option, and that is about the system understanding what else is out there, and that would be a key component of the Workwell partnership bid, we hope, would be a triaging function for that. And then the design principles, I might leave that one to you, Laura. How we design the Workwell thing to include those aspects that we've talked about the VCF and a place-based approach.
Yeah, so just around the governance question and the knitters, possibly not, is the honest answer. So the Sheffield Employment Skills Advisory Board was only established January 2023 and has made some really good progress, I've got to say. And the LIB is something that's been set up probably about 6 months ago to report into that group. And there is a direct link between the CSAB, the Employment and Skills Advisory Board, and the Economic Development Skills and Culture Committee. So hopefully but we need to see, because what we need to do some work on, and as Ruth said, we had a really good joint meeting with the voluntary and community sector last time, is this commissioning piece. And so we need to now make sure that the outcomes from that, which were, can we build these programmes so that we can commission hyperlocal activity, and for that to be the case, we need those commissioners to be working really closely together and having a synergy in the way that they commission things. So the learning was taken from that. That's now being fed back, and I think the Work Well fund, which has got an ambition written in black and white in it to commission hyperlocal services. Let's see what the outcome of that is, and the approach is going to be as a sort of proof of, are we getting somewhere, or do we need to do some more?
Yeah.
Okay, I have a number of people who have indicated they want to speak. The first one is Kate.
Thank you, and thanks so much for bringing this really helpful presentation. One of the things I wanted to just flag to members of the Sheffield Health and Wellbeing Board is a piece of work going on in Barnsley, which I think could be really informative for this. So Barnsley are leading a Pathways to Work commission with some really impressive global experts on the barriers to work and economic inactivity. My understanding is that commission is going to sort of do its first report in the summer, and the explicit focus of the South Yorkshire Mayoral Combined Authority, obviously which Sheffield City Council is a part, is that we make sure we take the learning from that commission, because although without wishing to disagree with my esteemed Director of Public Health, there are a lot of differences between our places. When you actually get down to the granular the neighbourhood level challenges we're seeing in some of the neighbourhoods that have the least positive employment outcomes are set out. I think there are huge analogies with places across the whole of the region, in fact across the country, which I hope that commission can help us with. So I just wonder whether it's worth us making sure proactively this board is kept up to speed with the outcome of that work, and that we're able to support the team to lean into making sure we get that learning for Sheffield rather than trying to reinvent the wheel. And then the second point would just be on governance, where I think actually my sense is that there probably aren't enough knitters, and as a spoiler alert from what I'm hearing from the Pathways to Work Commission, I think a lot of what's coming out is, unless the system changes, unless we find ourselves in a position where we are not dealing with multiple short-term, small, highly specified funding pots from different places, and that of course could change. Unless that changes, we need to have people who are able to do that knitting, and actually we've got, I think, the right infrastructure in terms of meetings and boards, but the bigger question for me is the doers doing the joining up. And then the final point linked to that, I suppose, would just be to say there is also, and this comes back to some of the points Judy made earlier, there's also the question of how the human beings we're talking about here interact with this incredibly complex system, and who has the role to be the person, the human being that's making that connection. And I completely endorse Greg's point about the importance of hyperlocal voluntary community sector, but also valuing that joiner-upper knitting role, which is something that I think we've seen historically underfunded for many years. So really good piece of work, and I think it's really positive that the Health and Wellbeing Board's talking about it. Oh no, I had one more thing, and sorry, apologies. I just think the point about how the role employers have on this. I think we should take this to the Pride of Place board that Helen and I both sit on, that is a employer business-led board that's emerging in Sheffield as a way of getting more input from business and the private sector into the challenges the city are facing, and making sure they're leaning into the city goals. And this strikes me as a really a good challenge to put at their doorstep, as well as our own as big employers. Sorry, Chair.
That's okay. Do you want to come in, Ruth?
Yeah, I agree with that. I think that's all really helpful, and I think we'd really welcome feeding in the work on employers into that board. That sounds really valuable. Thank you.
Thanks. I have James, Douglas, Lee and Judy on the list in that order.
Thanks, Chair, and many thanks both Ruth and Laura for a really comprehensive paper and presentation there. Probably unsurprisingly, I'm going to draw this back to mental health and actually take us back to that really stark stat that you gave of 65% gap in individuals with mental health that are receiving secondary care. As you both alluded to, there is for the lower level or more common mental health needs with NHS talking therapies, or IAPT as it used to be called, the Working Women programme, and for individuals with serious mental illness, the IPS, which stands for Individual Placement and Support. I think one thing that we need to really acknowledge as well in there is the NHS long-term plan funding, the previous funding for IPS should be mainstreamed and continue. I'm not proposing that anyone would have yesterday afternoon when the NHS England planning guidance 24-25 landed. Within that, though, it does show a commitment to increase IPS funding. So I think there is a challenge for us as a board in terms of how we're assured that the funding will be received by ICBs and received here in local places, whilst acknowledging there are significant financial challenges, but where there's new money coming in for a purpose, we want to make sure that that's received and actually makes the difference that we know it will make. The second point that I think could be interesting to pick up on is a number of community mental health services. There are 3 nationally recommended patient-reported outcome measures that are being introduced from next month. I know they're progressing well within Sheffield and starting to be used already. One of those is the Dialogue 10 scale. It tends to look at those wider determinants of health, one of which is employment. That's going to be starting to be used in the majority of community mental health services as part of an initial care planning, or part of assessment and ongoing care planning. That gives us a real strong opportunity as well for being able to evidence regular, frequent conversations with mental health practitioners and the people that are being supported around that employment agenda. Equally, what we do know is in the areas where we have greater mental health integration with primary care, with the voluntary sector, with wider determinants of health, Sheffield has a really high success rate in under IPS for individuals that have come from those integrated teams. So really shows the evidence of that integration, but actually the benefits on people as well. But thank you.
Can I take Douglas and then and then Laura can come back to both?
Yes, if you're on that. I just want to ask about more of the hyperlocal things, and really it's that point about what practical and financial support is there for people in the voluntary communities sector to help do this. And I think there's the categories of people there's other people who might be in work or might be out of work, but basically know to ask for help that might be going. And then there's another group of people who will basically not have the expectation of even asking. And that's where it's really critical that they're picked up by those services that they are engaged with, not thinking about a work thing. So, and I've actually, Laura, probably coming your way, I've got an organisation specifically in mind. So place-based, they've got assets, they have lots of people coming through, area of deprivation, they've got a plan, they already do a range of activities, and it's about engaging people, and they can see that there's some of these people who need moving on, otherwise they'll remain in chronic worklessness all their lives. They've got, the embryo and the outline of a plan to go forward there. It just needs doing. It's the voluntary sector, so in our terms, they'll do it on a shoestring, but the question is, what resource might there be available for them to look at? Based on what you said, I mean, is that the sort of thing that's going to depend on the outcome of the Work Well bid? If not, is there something that we could be talking about today? And I said, I had to pick up the specifics outside the meeting, but your general principle about supporting those hyperlocal things would be really good to be as specific as we can.
So I could come back on the point on mental health. That's really great to hear that I wasn't reading that document yesterday, so that's really great to hear that is going to be included in baseline, because I think that the evidence about including employment support with people with mental health problems is really, really strong, and that is why I think it's becoming more mainstream, because obviously you've got the local evidence, but the national evidence is really strong as well, so thank you for that comment.
Just in terms of support that is available to start off with, so I put that on the slide, a list of different organisations who have contracts within Sheffield, many of them voluntary and community sector organisations. Some of those are funded through the Shared Prosperity Fund, and those contracts were commissioned very late last year, essentially, and are only for a short period of time because that is the length of the time of the funding. And hopefully, if there is further funding at the end of that period of time, then there will be further commissions of those work. We very deliberately split up the contracts into sort of smaller value contracts that reward hyperlocal experience and knowledge, and that know about the other services that are available to support people, because often we are talking about quite a long journey. You know, it's not just a case of giving someone a bit of a help with their CV and off they go into work. This can be a long process that requires support with things like, you know, substance misuse problems, or an absolute variety of problems that I don't need to tell you guys about. And things like, you know, debt support services, having interview clothing. There's a massive amount of different support that is available. And then you mentioned about how people know about it. So at the moment, it's very much a case of organisations in their communities marketing their services. One thing that we are hoping the Work Well money might give us is a little bit more, that we can look at a more information giving, basically, so that people know where to go and who to ask. Yeah. And there is a job that needs to be done about clarity of pathways as well. So why would this one project be better to support this individual than another one? And that's some work that needs doing. Yes, so I think that answers your questions, Douglas.
Thank you. I have 3 more people who want to ask questions, and then I'll draw it to close if that is okay. So Lee and then Judy, could you ask both your questions, and then Laura and Ruth can.
Yes, sorry, I'm slightly distracted by some research on waiting lists and waiting list recovery and joblessness. So I'm trying to formulate my question. Let me speak and it'll come to me. Really welcome this. In general practice, I'm just reflecting on how much of our workload is all about people's employment or lack of it, how that impacts on their health. Is it a clinical risk or is it a clinical asset? Does it help people get better? All the things you talked about. I was minded of Claire Gerard was on the radio recently talking about this very topic, and she said any job, good or bad, is good for your health. And I would counter that, because where I work, a job that makes you do 2 8-hour shifts back to back, standing in a refrigerated unit, chopping off chicken breasts by hand, is not good for your health. So things which have helped us working with people who are struggling either in work or trying to get into work, or having the SOAS advisors based in practice, that was really brilliant. Working WIN has been really brilliant, particularly people with mental health conditions as well. So there is stuff that works, but when we're thinking about how we can work with employers to support this, it's great if you have sort of big employers who are really switched onto this. A lot of the time we're dealing with, particularly where I work in that map, those dark areas in the map, employers who may not be quite as aware of this. I can give you an example. A chap who was lifting heavy stuff with no health and safety, had a terrible back strain, came to see me, had been given a sick note the previous week by another GP for 2 weeks, which was actually entirely reasonable for that condition, and that week had received his P45 from the employer, backdated to before when he'd injured his back. Do you know, and he'd lost his job because of the injury that he'd sustained working for them. Do you know that's the sort of world that we live and work in? So I think there's a question for us as a board: what influence can we have with all employers? You know, what sanctions are there? What support, whatever it is, just to really help people. I think it's really important. But just my point I was going to make about the whether it's a national move to address waiting lists by factoring in inequality or employment. You know, if somebody's waiting for a hip replacement, do you prioritise the chap who's going to lose his job over the one who can actually still work from home, even though he's got arthritis in his hip? You know, it has been done. So that's what I was looking at. So in Coventry and Warwickshire, they've already done that, and the Midlands and somewhere else. I can give the figures after the paper afterwards. Is looking at looking at inequalities and joblessness or precarious employment as a clinical risk factor, and have actively taken steps to factor that in when they're looking at their waiting times. I have had conversations in Sheffield with trusts about that. Some are more open to it than others. Some of it came as a complete surprise. And again, that feeds back into this very pressurised system that we're in, where people are just told you have to reduce the waiting list no matter what. You just do what's expedient, not always what's the best thing that in the long term is going to save us all money. There wasn't a question in that. I'm sorry, Angie.
It's okay. No, that's fine. That's why we're here. Judy, did you want to come in with yours, and Megan, and then if there are any kind of answers that need.
I hesitate to add anything into this, but just wanted to ask you about volunteering and how that helps people who are some way from the labour market to get a bit nearer it, and particularly that seems to be good work isn't always paid, but it does help people, particularly with mental health issues. And is that somewhere else in here? I've missed it, or where is it? Because I would have thought that that needs to be integrated into this new world that you're developing, but I don't see it.
Yeah, no, that's a really good point. Thank you, Judy. And I want to come back on that point on volunteering. You'll know in the health and wellbeing strategy, it says a fulfilling occupation. It doesn't actually say paid. And it's really tricky because on one point, me and Laura know the massive value of work, but we also do have to talk about the massive value of getting paid, because that is important for people in poverty. I think volunteering is really important as a route for people getting work. It is really important to give people a purpose and a fulfilling occupation. Paul Harvey from Voluntary Action Sheffield is absolutely relentless in reminding us of the importance of volunteering, and he's quite right to do so. So I think we would all see that that is important in itself for people's health. It's important as a route to work. I'm sorry I didn't include it in the paper. That was a mission and I should have done. But that is definitely something that we consider when we're talking about developing skills and developing confidence to get into work. So thank you for raising that.
And very interesting, at the ICP, when the Barnsley project was presented, was it a Barnsley project? I think it was. Volunteering was raised, and the fact that DWP doesn't recognise volunteering as a meaningful activity. So we need to challenge that. It's really important. And, I work for an organisation that wouldn't exist without volunteers. We just wouldn't be able to make it work. Megan.
Thank you, and nice to see you both again, because I was at the last CSAB, I can't remember what it stands for, Skills Board meeting as a voluntary sector representative there, talking passionately about what we do at a hyperlocal level and the risks around the funding. So I suppose a kind of question and comment really. Within the 3.5 million bid that's been submitted for South Yorkshire, I'm just wondering, at that bid stage, to what extent have voluntary sector partners been involved or integrated within that? Can it be shared with voluntary sector partners who might have a potential stake in that? And part of the reason I ask is, people have talked about the success of Working Win and the IPS model of working, but I know that at a hyperlocal level, a lot of us who provide employment support services aren't trained in that, and I think that's potentially a skills gap. And if this work goes purely in the direction of that kind of IPS model, then I think that it could cause us some really big problems. And one of the things that we talked about at the Skills Board was how we ready ourselves as a sector in Sheffield for this work to come through, and whether or not we need to re-establish some of those consortiums that used to exist previously, such as Sheffield's Working, in order to be able to have the capacity to work at a citywide or even regional level, sub-regional or regional level, not just at our own hyper-local level. So it's just about support really, I suppose, for us to be able to do that.
So in terms of to what extent was the sector consulted, it came to the LIB partnership as the bid was being put together. So there is voluntary and community sector representation, particularly where they run projects that have a health and work sort of crossover. So it did go there, but it was one of those things where DWP had put it out. It had a month to get back, so it was limited in terms of the consultation that was able to be done. I don't think it can be shared because I think it might potentially cause some commercial issues, and obviously if we want the organisations to be able to deliver against that project, which I certainly very much would, then we have to be careful about actually sharing the bid. But I have given a presentation around the bid, and I'd be happy to do that again, Megan, so that's no problem at all. In terms of whether it could be used for training, I don't know, but that's a very good point. And as I say, Simca has put in the bid as a managing agent, if you like, for the ICB. So it is not within my wit to say exactly what is going to happen as a result of it being successful, but because you were at that meeting, that we very much did speak to Simca about the way in which you can incentivise and provide hyperlocal delivery, and that's something that, as you know, I promised to be following up. So it's not within my wit to say entirely what's going to happen, but that's our intention.
Could I also come back on some points that Lee made as well? I think it's really interesting to see what's happening nationally in this space. So, for example, Dame Carol Black, who's been really influential in the area of work and health, has been tasked with, and I'm going to get the name of it slightly wrong, but a commission to look at occupational health provision, because there's a lack of occupational health provision in this country. People who are occupational health trained are getting to the end of their careers and there isn't the workforce. So to look at that, and also one of the things that we've been asked, people were asked as part of submitting a Work Well partnership bid, were asked, if you're successful, will you work with us on fit notes as well, please? Because we want to do some work on fit notes. So there's a whole load of national policy change that needs to happen to facilitate some of these things that we're talking about that don't really quite work. So when I put occupational health providers on that slide, I thought it's really a very limited number of organisations who have an occupational health provider now. And that is one of the issues that we've got. And also the point that you were making about signing off a fit note. That's been a really complicated, it's really doesn't quite work kind of issue for a long time. So I think there is national recognition that you need some national action on some of this as well.
Thank you. I have two more people who indicated. So Helen and Greg, if you want to both speak, and then we'll see.
Yeah, thank you. As you were talking, so Voluntary Action Sheffield have been consulted about that bid, and we're pleased to see the commitment to hyper-local delivery within it, and the thinking here clearly is indicating that. And clearly a lot of knitting is done at that level. If we're going to talk about knitting, we work hard, don't we, in communities to join things up for people in the place that they are. So I just wondered, just thinking perhaps about the city goals and how they sort of frame that, understanding that people can see what they need and what works best for them, whether the commitment to local delivery might lead to some local commissioning, because it still feels that it's very much designed at a level, this bid, for example, at South Yorkshire level, but actually, might it lead us to that sort of space?
Greg?
Just very briefly, you mentioned the Dame Carol Black review. There's genuine interest across DWP and DHSC on nailing this particular topic. We don't know the answers to many of the difficult, thorny questions. That's why they're wicked problems. I think we'd all agree with the recommendation that we become masters of our own destiny and control what we can control. It's sometimes against the grain, sometimes with the grain, but this government, don't know, the future government will be the same. They will want to be in this space because it's right from any number of perspectives. So I think it's up to us to push the boundaries on that one.
Great. I had some questions, but they've mostly been answered. But there are some, I want to read out the questions that you posed because I think they're important for the board to hear. So, how can the Health and Wellbeing Board support employers to have positive working practices, including providing reasonable adjustments and workplaces which support good work? So I think we all need to take these questions back to our organisations. What can the Health and Wellbeing Board contribute to stitching together of the services to support people with health condition to get and keep a job? As organisation linked to health and social care, how can we provide good work and support people to get and keep a job with us? How can major employers work together on this? And how can service provision support people to get or keep a job, including supporting people on waiting lists by linking with employment support. The reason why I wanted to read the questions out is because I think, we talk about governance and accountability of who's accountable in this board. So I think it's important that maybe we put something in our work programme about coming back to these and how we take the questions back to our own organisation so that the partners then can start thinking about it. I think there is a lot going on in the city already, with the city goals. Kate mentioned, the connection in terms of employers, the being employers. I think in terms of the council and the NHS, for example, we need to do our laundry ourselves in terms of what kind of employers are we. I know we're doing a lot of work in the council on this. So are we providing people with with good pay, secure jobs? Are people being valued? Can people progress? Are people happy at work? Because if we need to do our own job first, same thing in the NHS. How many people are off with stress in the NHS, in the council, in the big employers in the city, the universities and the big businesses. So if we can get the big partners to do their own homework and come back to us. And I think today we are asked to note the importance of employment, health and well-being, take opportunities to advocate for good work as an important determinant of health, including the role of employers, providing good work and supporting environments, supporting the work of the Sheffield Skills and Employer Advisory Board to develop the employment and skills strategy, supporting the work of the local integration board, stitching together support for people with health condition to get and keep a job, and 3, to provide good work for employees in their organisations. So are people happy with those recommendations? And Dan, could you put something on our action log that we want to come back to this maybe in 6-9 months? Zach?
Sorry, just really quickly, I think it is really important that we all lead by example on this. So, staff well-being is really important and productivity is linked to well-being. And we've got the insight to accept when we do have work to do. So, certainly from an ICB perspective, when I look at our staff survey, we do have a lot of work to do. We've got an excuse that we've been through a big reorganisation, but there are things that could have been handled better. And I think that insight is really important if we're going to lead by example and actually challenge some of this in the workplace, because it is absolutely critical. Final comment, just as a GP, I used to spend a lot more, or I used to have a lot more time that I could spend doing this, and it is really important, but it is something that, because of the pressure within the system, you don't have the time to sit down with patients and go through the benefits of working and encourage them. And quite often, I used to work with them and their employers to try and encourage that environment that could get them back to work. So I guess it's a regret I've got, at this stage in my career, that was something that I had much more time that I could do, and I certainly did a better job 30 odd years ago.
Thank you. And we're having a 10 minutes break now. Get a drink. Okay, welcome back. We are on item 8 of the agenda. This item was circulated separately from the main bulk of the agenda, and I think Janet is going to present. Thanks, Janet.
Hello everyone, good afternoon. My name's Janet Kerr. I've realised my title on my little badge is wrong, so I'm Operations Director in Adult Care. And I'm here to talk to you today about unpaid carers. I'm the strategic lead in adult care for unpaid carers, hence why you've got me today. So, but I want to say the work around unpaid carers is done by a couple of people, Lee Teasdale Smith and Mary Gardner, who do a really, really good job. And Lee, I often say, Angela's heard this before, I open my mouth and Lee's words come out. And that's what's going to happen today, because Lee's basically given me a script for what to say today. Right, so before we talk about the report, I'd like to start with a quotation from an unpaid carer. It is in the report, but it's worth repeating as it captures the essence of what we're trying to do with the Carers Delivery Plan. And the quote is, "Some people can shout and make others understand what they need. Others find that hard. None of us ever thought we would be carers. That's our job. Just make sure you're all doing yours right for people like me." So I've come to the Health and Wellbeing Board today to provide an update on the Carers Delivery Plan 2022 to 25. The delivery plan was approved by the Council's Adult Health and Social Care Policy Committee in December 2022. The report for today has 4 recommendations for this board. To recognise the progress we have made with the Carers Delivery Plan, to state your commitment to reducing health inequalities for unpaid carers so they feel recognised, valued and supported, request an update on unpaid carers every 12 months to provide assurance and leadership on reducing health inequalities for people who are unpaid carers, and sign the Young Carers Covenant. This involves committing to an action or actions that will help young carers achieve an outcome or outcomes from a list of 10 that have been co-produced. Of most relevance to this board is that young carers have good physical and mental health. To briefly recap, the Carers Delivery Plan is how we make our young carer, parent and adult carer strategy vision a reality. Carers want action, not just the status quo, and the delivery plan makes it clear to carers what we are going to help them do, what we're going to do to help them live the life they want to live. We know that together we get things done, and the delivery plan embodies the council value. The delivery plan is multi-agency with key partners such as Sheffield Teaching Hospitals, Sheffield ICB, Sheffield Health and Social Care Trust, Sheffield Young Carers and Sheffield Carers Centre, all making amazing contributions. There are many important reasons that we need to help our carers. Carers provide essential support to some of the most vulnerable people in our society. We need to be proactive and respond to carers' needs, or we risk compromising the health and well-being of carers and in turn the health and well-being of the person they care for. Carers are vital to our communities, and without this unpaid workforce, our health and social care systems would be severely compromised. There are approximately 60,000 carers and 7,000 young carers in Sheffield, and with an ageing population, unpaid carers will be even more important in the future. This is why we need to focus on supporting carers, including preventing, reducing and delaying their needs for support. Caring can be incredibly rewarding, but for some there are real difficulties. For example, in Caring as a Social Determinant of Health, a 2021 report funded by Public Health England, the conclusion was that carers experience poor physical and mental health, struggle to access services and are at risk of financial hardship. In the NHS long-term plan it states, carers are twice as likely to suffer from poor health compared to that of the general population, primarily due to lack of information and support, finance concerns, stress and social isolation. The Joseph Rowntree Foundation reports that 44% of working age adults who are caring for 35 hours or more a week are in poverty. Applied to Sheffield using Census 2021 data, this means approximately 8,000 carers in Sheffield are in poverty. Caring can have both an immediate and long-term impact on our children. This includes an increased risk of anxiety and depression, impacting life chances due to lower educational attainment and increased likelihood of not being employment, education or training. So the evidence is clear that caring can negatively impact people, including their health, which is why it is vital that we act. To show we have done this, I just want to touch on some of the key highlights from our delivery plan in the last 12 months. Sheffield had its first Carers Roadshow in which 33 support agencies attended. There were 71 mini health checks delivered by community nurses, 1,728 contacts between carers and support organisations, and 2,041 pieces of information given out. We launched the Multi-Agency Carers Strategy Implementation Group that oversees and adds to the delivery plan. The Council's Adult Social Care Outcome Framework scores for carers have increased in 4 out of 5 measures, including the Quality of Life score. Sheffield Carers Centre created their involvement network so that carers can help make decisions and co-produce policy. And Sheffield Teaching Hospitals created a carer passport to help support carers who are visiting the person they care for in hospital. Looking forward over the next 12 months, we want to work with carers and partners to identify even more carers, reach into more diverse communities, sign the Young Carers Covenant, sign No Wrong Doors, which is a memorandum of understanding between adult services and children's services to support young carers, ensure more young carers get added to our Young Carers Register, and complete the Carers Centre carers strategy. In conclusion, supporting our carers via the delivery plan makes moral, ethical, legal and economic sense for us as a city. We know that in the last 12 months that the carers delivery plan has positively impacted the lives of carers, but there is still much more to do, including improving health inequalities that carers experience. So I've got some questions for the board. So how can this board support Sheffield to become a carer-friendly city? Can unpaid carers be cited in our new health and wellbeing strategy as an important cohort to support? And can members of this board help raise the profile of unpaid carers so we are able to identify more of them in our health and social care and education systems? And just finally, I'll mention, because I plug this every time I talk about carers at the moment, there is a Western Park Museum, an art display from young carers. It's something the Young Carers Centre did with their young people. I went to, actually myself and Meredith Teaswell were at the launch, but just if people are nearby, it's worth having a look at that. And I spoke to some of the young carers who'd taken part in that work. So I just like to squeeze that in whenever I can.
Thank you. Yes, and the exhibition is really, really good. I really recommend it. I went last week. Are there any questions or comments? Go on.
Thanks, Janet. Dead helpful paper, really good summary. Just to kind of pick up on the questions in particular, I'll declare an interest as an unpaid carer, though I'm paid quite well. How can the board support Sheffield become a care-friendly city? There's something about covenants and charters, there's something about hearts and minds, there's something about action plans, and I don't know whether the sort of the stakeholders who are represented on the board are signed up, are cited and signed up to the action plan. It's the what happens on Tuesday, what happens a year from Tuesday. There's yes, but with that caveat for me. The second question, can unpaid carers be cited in the health and wellbeing strategy? I personally wouldn't be against it, but there's just a limit to how many specific things one can name check in a high level strategy, because the board get asked to, can you do this, that, the other, and it becomes a strategy that's this thick, that becomes this thick. So yeah, yes, but with that caveat in mind. I had a third thing to say, but I can't remember what it was, so I may come back to it.
Thank you. In terms of the recommendations, there is a discrepancy on the ones that are printed at the front of the report, which is the official recommendations, and the one that are at the end of the report on page 9 of the report, which include signed the Carers Trust Young Carers Covenant. I am not sure why, and sorry, I didn't spot it straight away. I needed it done, so I feel like justified on not spotting it. So I'm not sure why the last one was not put at the front. I don't know whether there is a reason Democratic Services have taken that one out. I've not been made aware. So can I suggest that we take the first 3 recommendations, which is recognise the positive progress made in Carers Delivery Plan 22-25, state their commitment to reduce the health inequality for people who are unpaid carers, so that they are recognised, valued and supported, and request updates on the carers delivery plan and subsequent carer policy every 12 months. And I know 12 months seems a long time to wait, but maybe we can, work out whether we can then sign up to the covenant at that point, if that is okay. So are people happy with that? And could we put it in the work plan that we're waiting for a report back? Thank you so much, Janet. And thank you to all the unpaid carers in Sheffield. So we are on to item 9, which is the annual report of the Joint Health and Wellbeing Strategy, and is going to be presented by Susan. And Greg, are you not presenting? Oh, Dan.
I'm going to go first and just say a few things about the annual report to sort of, I think, probably frame and things that we'd like you to be thinking about as Susan is talking in the conversation that follows. So the annual report, just to remind you all, is something we instituted last year as part of the sort of trying to establish clearer accountability arrangements around the board's work. The purpose of it is to sort of look back at the conversations the board has had, where it's chosen to direct its attention over the previous year specifically, but also looking further back for longer term pieces of work, and to try to identify where we are seeing impacts or changes that we can tie back to those. So it's not about sort of looking at all the activity that can or can't be linked to the health and wellbeing strategy. It's trying to draw the link between the conversations that happen in this place and the work that the board commissions, and whether that leads to impact on the ground. So just some short comments and identifying the key points to inform that conversation about the strategy. Some positives that the report identifies, and there's the agreement that the board executes its statutory functions effectively, so its sort of assurance role around the Better Care Fund, its relationship with Healthwatch Sheffield, and ensuring it's sort of factoring in what people are saying about health and social care in Sheffield into the work that it does, is all sort of in a good place. And it also identifies some areas where the way the board has worked, the things it's chosen to focus on, have led to some changes and some impact on the ground. So sort of its role in joining up across policy areas, picking up employment and health, which you've heard about today, housing and health, which I think we will hear about in future meetings, and then culture and health, which we heard about a couple of meetings ago. All examples of where the board is sort of supporting people to draw the links between different sectors and their impact on health, and create partnership work to make progress as a result. It also identifies a couple of areas where the board has commissioned work which is leading to impact, and the big example it picks out is that of Compassionate Sheffield, which sort of played a big role in the pandemic, but also continues to reshape the way we approach end of life in Sheffield as we go. There's also some areas it picks out that are maybe less positive, and I think it's possibly these ones we want to dwell on a bit more as we're thinking about the health and wellbeing strategy and what good implementation of that strategy will look like. Picks out the sort of 2 deep dive sessions that we ran over the last year, the one focused on mental health and wellbeing and the second on children and young people. Sort of notes that those were sort of a good resource for the board in terms of providing in one place a really strong overview of areas that are hugely relevant for health and wellbeing now and in the long term, but that the way those sessions worked maybe didn't provide what we would have wanted to get out of them in terms of clear actions and where to go next. And there's some reflection, I think, about what that means for the way this board works, how it uses at times, if it wants to run sessions like that, the conditions it runs them in, and whether it seeks to sort of take them out of the formal setting. The other point sort of it picks up is around accountability for action as a result of discussions that happen at the meeting, and it picks up a number of points where sort of actions have been agreed, and it's maybe quite hard to see whether they've been taken clearly. It's always difficult in the partnership space to sort of engage in that kind of hard-edged accountability work, but it's something that I think if we are talking about effective delivery of the health and wellbeing strategy that Susan will be talking about over the coming years, something we need to think about quite heavily and clearly to think about how we can be confident that the right actions are being taken and everyone's taking the due responsibility for pushing things forward. So I will stop there as those sort of key points to pick up and hand over to Susan to talk about the strategy itself.
Thanks, Dan. And I think I know most people in the room, but those who don't know me, I'm Susan Hurd. I'm Assistant Director of Public Health here in the Council. You'll see that, firstly, the paper was actually written by Helen Watson. Helen is supposed to be here, but she's not very well. So I'm going to do my best to take you through what she'd intended to say to you. So bear with me, and hopefully I'll do her justice. So this is bringing you an update around the development of the new strategy. As a reminder, which you probably don't need, the Health and Wellbeing Board has a statutory role in producing this strategy, and the overall purpose is to set the key priorities to improve health and wellbeing in Sheffield and to reduce inequalities. We really want to acknowledge the strategy editorial group who are named in the paper and say thanks to them for their commitment to this work over the last 9 months, and to everyone who's contributed to the development of the strategy so far, and that's board members, people from partner organisations and sectors, and the people of Sheffield themselves. So we're mindful that the process really matters. There's no point in myself and Dan and Helen just writing some words in a dark room. It's not going to get us to where we need to be. So the work has really depended on the generous and honest contributions from all of the groups I've named, and people's willingness to share perspectives and experiences, their hopes for the future, and bringing constructive challenge along the way. We've had feedback that people involved have felt valued and listened to, and that we're talking about things that might be difficult, but that people feel we really need to tackle collectively. And we've also heard that the visibility of this board in the process, particularly in hosting the public workshop, being on stage, so that's the workshop at the end of January this year, being on stage and presenting honest reflections and facilitating table discussions was really appreciated by the people who participated. So really thank you to those of you here who were involved in that. There's been reflection, as Dan said, that much of the content of the last strategy is still very relevant and very important, but also a sense of frustration and disappointment about a lack of momentum and determined action in the past. What we're hearing from people is that we can't keep doing the things the way we've always done them, and that there's a strong desire for the strategy to encourage new thinking and new bravery across different parts of the system into the future. So our overall approach to the development of the strategy has been to look back, where have we come from, and create space to reflect on that strategy and what has and hasn't been achieved and why, what we can learn from that and what we want to take forwards. We're looking around at where we are now, reviewing data and insight we have about the current state of health and wellbeing of people across Sheffield and the unfair gaps in length and quality of life between different groups of people. And we're also looking forward to ask where do we want to get to and develop a clear overarching aim and vision for the new strategy. And then to co-design the way to that shared vision of the future by reviewing a range of evidence and frameworks from the academic literature and other publications, and creating spaces for deep listening and critical conversations with the public, with partners and with board members to identify the good we already have that we can build on, what more we want and need to see, and what is essential to enable us to make progress. So what we have now is a clear understanding of what really matters to people in Sheffield for a good life, and that the vision for the strategy is to close the unfair gap in length and quality of life by improving the health and well-being of those worst off the fastest. There's also an acknowledgement that this is going to require a long journey in the same direction, so we're recommending to you that this time around we have a 10-year strategy with reviews every 3 years, and then that 10th year is a bigger review, and 1-year delivery plans that align with the fiscal year and the board reporting mechanisms. The shape of the strategy in creating a path to that future we want looks like the 8 foundational building blocks based on the work of Professor Sir Michael Marmot and 4 radical shifts. And those of you who were at the workshop on the 30th will have seen those and discussed those. The 8 building blocks are the foundations for a fairer and healthier future for Sheffield, for people of Sheffield. This is what we need to ensure is in place to create health and wellbeing for all. We've heard about lots of good work already underway which align with these building blocks and that we can build on. We've also heard about areas where we need more focused action, and we're currently collating all these contributions to refine some areas for you, the board, to consider for prioritisation. The 4 radical shifts are the how of the strategy, and are critical for making it more than just a grand ambition or inspiring words. And Kate, actually, you said something to us, to Helen and Dan and I a couple of weeks ago, about this being, we can see the top of the mountain where we're trying to get to, and that's the vision of the strategy. But there's a deep dark wood between where we are and that mountaintop, and the deep dark wood is the 4 radical shifts. This is where we need collective bravery of board members and partners to make bold commitments to the journey together into the unknown, and to do things differently in the allocation of resources, in working collaboratively with each other and with communities, and in how we hold each other to account, and in developing leadership and a thriving workforce. We've had a lot of input about what it would look like if we made these shifts and what it would take to do it, and we want to bring these challenges for action to the board in a May workshop where you can explore the brave and bold commitments needed to make them a reality. So, very briefly, and I'm just last bits from me, next steps in the development of the strategy are outlined in the paper. A couple of things to pull out and highlight. We've heard from different partners that ensuring that there's a clear narrative about how this strategy, the health and wellbeing strategy, and the city goals align is really important. So we've started the mapping work looking at how the 8 building blocks link across to the delivery of the goals, and we actually can already map all the goals to different building blocks. It's completely represented, which is a relief, but also perhaps not surprising. So we're going to continue to liaise with the City Goals transition team to identify where there are areas of synergy that we can capitalise on and where we can avoid duplication. For example, the City Goals cornerstone indicators work will be informed by and we will take information from around the development of indicators for this strategy so we can understand if we're travelling together in the right direction. Another thing to pull out from the paper is in terms of what the strategy product's actually going to look like. We've heard that people are keen for the strategy product to be something that's tangible, accessible, a living document and interactive, something that enables a connection between the board and the people of Sheffield, and something that can evolve and tell the story over the life of the strategy. So we're working internally with colleagues to look at a more interactive way of doing that, whether that's some kind of microsite for the board and the strategy is hosted on that. There is likely to be some form of traditional written document, but we're hoping to have something that's more alive than that is the main thing that people will see, with perhaps something written in the background. And then lastly, in terms of finalising and publishing the strategy, the intention is to bring this for agreement to the June 2024 board meeting, so in June this year, and then finalise and publish the interactive format by the end of the summer. So that's all from me. Just the questions or the ask of the board today. Do you want me to run through that, Chair? Yeah. So the ask of you today is to note the strategy development journey and the timescales that we've outlined, to support the revised implementation period moving from 5-year to 10-year strategy, to participate in a private spring workshop for the board to agree priorities and develop commitments related to the 4 radical shifts, and to provide any additional steer to the development work. Thank you.
Zach?
Yeah, thank you. I think it's a little bit like the cleaner at NASA, isn't it? You know, we've actually contributed to doing a lot of really good stuff, haven't we? But just think if we actually had that shift of resources that we always talk about, how much we could actually do. And then that links to the conversation we had last board, which was, I think I described it as how we choose to invest our money in Sheffield, and where we might choose to invest it differently if we really wanted to make a difference. And then that links into the national stuff, which effectively tells us quite often that we have to invest our money in a system that probably we all feel will not work. So it's the illness factory medical model type approach, disproportionate shift into that, where we talk about left shift. So it's the complete opposite of what we're trying to achieve. And I guess the question then is, probably 2 choices. You either build a hospital that just covers the whole of Sheffield, or are we genuinely going to try and change things? And what is the commitment from the partners, which on paper is there? Is it real? Is it genuine? Are we going to actually get that? I think I described it as a juggernaut of change that's going to start to take some of that forward, because we've got to. The current model is not sustainable. You know, the the NHS medical model bit, it will disintegrate if we don't shift to wellbeing. It has to happen. It's just a matter of how long before we realise it has to happen. The big fear I've got, if we leave it too long, it could be too late to do some of this stuff. So I guess that's the bit I'm really keen is, you know, we all say we're committed to it. We all then choose, or sometimes we're told to invest the money in what many of us would say is the wrong place. How committed are we to actually trying to shift some of that stuff around? And part of that is then linked to some of the difficult conversations about if we're going to free up resource to do this, what we're not going to do. And then some of that becomes a really difficult conversation, because actually, if you're the individual that could actually get that high-end, high-cost care that we're saying we can't do, that is a big personal issue. Or if you're a family member of that individual, but the gain that you can get from shifting that resource into making a difference for 1,000 people could be massive. And that's the bit for me is, you know, are we, well, I mean, I think personally, I think we've got to go there. Are we brave enough? How bold are we going to be in doing some of this? And then how do we actually sort of map that through the progress through the Health and Wellbeing Board, which is that bit about, do we have to have maybe brief updates on where we're getting to with some of that direction of travel?
Can I take Greg and Judy, and then if there are any answers, you know, Zach seems more like a comment than a question, so Greg.
No easy answers to these. As it comes no surprise, I'm really comfortable with where we're getting to on this one. A minor point, the sort of the good life thing, notwithstanding the 80s sitcom parallels. There's something about how we frame our language and sort of framing it about enabling environment, not context of individual actions. We all just need to take care on that. Fully support 10-year. You mentioned it in passing, the sort of the microsite thing. I think we should strongly support that, because it will be as good as we communicate it, actually. So I think we should kind of put a bit of energy into the microsite thing. I don't know what that means in practice, but we should go there. On the workshop, yes, definitely, yes to the difficult choices, and sort of to use Kate's analogy, the mountaintops and forest. We design chainsaws at the workshop to cut our way through the forest. We broadly know what needs to be done. The one thing I'd really emphasise in the kind of the getting on with implementing it is the sort of the knitting and coordinating it all together function. We know we'll do that. We've heard about that in the work health thing that Laura Ruth did, and that holding our nerve when we know we've got it right, we know we've got good practice, we all know that there is plenty of it, but sometimes we don't hold our nerve when it's difficult to measure the impact or the outcome. So that's a sort of an implementing down the line point, but all up, I'm dead comfortable with where we've got to.
Thanks, Greg. Judy.
Yeah, thank you. Less on content, I agree with what's just been said, a little bit on process though, and picking up the paper on the annual report and the first bullet point about how the board works. Just remembering that the board used to have development sessions which were about how we as a group work together. We haven't done that for quite a long time. It seems to me, I'm taking the analogy of the mountaintop and the wood, which I've taken with, if we're going to do that, seems to me we need to understand each other better, each other's sector, we need to trust each other more, and that brings about some sense of shared accountability. We meet in these really rather formal settings, and I've never spoken to Paul, I've met you, I don't know what you think. We need to do more of that, it seems to me, if we're going to make this really work. That's one bit of process. The other one that I've been taken with recently, as well as the mountaintop, is the Marmot cities seem to have a governance setup which focuses on health inequality alongside the Health and Wellbeing Board. And I think that's quite an interesting concept, led by the leader and I think the chief exec of the Mrs. Coventry Council. So just throw that into the mix. Thank you.
Thank you, and I'm going to throw my own little bit in. There are two sets of recommendations, because the report is in two parts, 9A and 9B. I just wanted to make a couple of comments about the first bit, about the annual report, and very much along the line of what Judy just said, is I was wondering whether if we decide that we still want those deep dive sessions that we have, then we could have a development session where we get together, which is not a public meeting, where we get to the how we're going to do it, and then maybe ask the partners to report, you know, to do a very quick report in a year's time, how they've implemented whatever we agree as actions, so that we have some kind of sense of accountability. You know, maybe all partners could have like an annual report of their own where they have to cite whether they have or not done any kind of shifts because of things that we've supported here. I was just trying, yesterday I was just, you know, rereading the papers, and I was thinking, what can we do differently? Because we talked about governance and accountability quite a lot in the, you know, in the steering group, and how do we do it? Because we can't make people do things, but how do we at least, you know, hear what people have done if they have done something? And in terms of the you know, the development of the strategy, I just wanted to say thank you for all the work that's gone into this, because I've taken part in quite a few of the sessions, and you know, the amount of work that's gone into it has been enormous. So thank you very much for that. Are there any other people who want to say anything? Okay, so we've got two sets of recommendations. One, for the first part, is to endorse the annual report and to agree to incorporate the issues raised in the annual report into a development session focused on the delivery of the joint health and wellbeing strategy. And the other set is the ones that Susan read out. So are people happy to agree those? And is it okay if we suggest that we do like development sessions and we work them into our next kind of municipal year program? Greg?
So I agree. What I was going to mention it under AOB, but I'll mention now, one of the things Dan and I have been talking about is the sort of, in the dim and distant past, the board meetings were monthly. There were sort of quarterly set piece meetings, aka this, and then, you know, between the quarters, monthly meetings. Quarterly is not frequent enough, actually. The management of the agendas, as we all know, is a bit of a nightmare. We may need to come back to more frequent meetings. If we frame that as development sessions, so be it, but we may need to come back to it.
And also, I also wanted to comment on the strategy. I wanted to say thank you for incorporating the fact that we're going to try to make it match with the, you know, with the fiscal year and also the municipal year, because it's a bit distant. So that was one of the comments that we gave as councillors. So thank you for that. So are people happy with the recommendations? Thank you very much. Brilliant. So we have, thanks Susan, we have item, and Dan, we have item 10, which is the forward plan.
This is me, I'll be quick. Usual ask, please. Up to you all to suggest agenda items, otherwise it's what I think is interesting, which you may or may not agree with. June is looking fairly full. As trailed, we'll have a near final version of the health and wellbeing strategy by that time, and we intend to ask the ICB Chief Exec and Chair to come and update on what they said a year and a half ago, I think it was. So I've emailed the PA this morning. September we may come back to the spend outcomes thing where Jackie Mills, Chris Gibbons did a while back. We may come back to that. As ever, we try and get the right mix of agenda items across the totality of all things that contribute to health and wellbeing across all stakeholders and constituencies, things that work really well, but also stuck, difficult, wicked issues. You need to tell me what you think you need on the agenda. You can do so now, or you can drop answers on a postcard.
I think Douglas wants to say something, and okay, from my point of view, can we just add the things that we've mentioned today onto the next one, please?
Yeah, mine was health and housing. We actually agreed at the last meeting, because it's in the minutes, to add a review of the health and housing situation. So yeah, can we make sure that goes on the agenda? Don't know when, so it could be a bit of a floating item, but so we don't lose sight of it. Yeah, thanks.
So the next item on the agenda is the minutes of last meeting. So they are on page 103 of the paper. I'm going to take them as correct record of the meeting, unless someone says no. Are there any matter arising apart from the agenda item for the work plan? I only have one in 3.2 on page 105. There was member also requested that the board write to the Stocksbridge Town Deal Board to make sure that the premises were made. It's in the context of the public question about pharmacies. Was the letter written?
Not to my knowledge, Chair. Omission, my part, take full responsibility. There was going to be a meeting, I think, Zach.
We had the meeting.
So
Yeah.
well, I'll liaise with Zach and we'll work out the format of the letter.
Brilliant, thank you. So are people happy to accept those minutes? Fab. So I have a number of A or B, not from me. I'll give Greg precedence, then Dan, then Paul, then Kate. It's the last one.
Thanks, Chair. I'll be quick. 4 parish notices. One final call for board members for any comment on the refreshed ICB joint forward plan. I've had some, Lee, thank you, I've got yours. And I've had a few others. The short version is the plan says broadly the right things, but needs to better engage with some of the fundamental issues within the system. So any final call for that? Otherwise, I'll concoct a response back to the ICB based on what I've got. 2, just to note, board chairs have been asked to respond to an NHS England letter about the ICB annual assessment. I'll draft something and circulate it to 2 co-chairs so that you're cited on that one. And there are 3 broad questions. 3rd AOB from me is Prof Mike Marmer is in town, part of the Festival of Debate, on the 21st of May, 6 till 7:15, Sheffield, Hallam. Venue is got 450 people. Tickets are selling, well, they're not selling, it's free. Tickets are going fast, so if you want to register, please do so soon. 4th AOB from me, just to note, Chief Medical Officer Professor Whitty was in town 2 weeks ago, looking at his next annual report, broadly focused on the health of cities. It was a really, really good visit. Thank you to those who helped organise and or facilitate the sessions, and thanks especially to Matt Dean from Zest who hosted us for the day. So that's it. I told you I'd be quick.
Yes, just to flag with the board that adult social care colleagues are putting on some online partnership workshops focused on honest and constructive feedback on progress made, improvements required, futures activities planned to benefit services in that area. I will email out about these after this meeting to sort of give you a bit more information, and we will also send invites on to you if you want to book onto those. Just to flag that that's coming.
I'd like to introduce, if I could please, Angela Greenwood from the RU to talk to us briefly about Safer Square initiative that took place over Christmas and into the new year. Just give us an update on what that achieved for us, and I suppose just to raise some awareness and invite a little bit of discussion upon what that has done and what that potentially could do for us. Thank you.
Thanks, Angela. Sorry you had to wait the whole meeting.
No, it's been fine, thank you, because I've been nosed, I've been listening in, so it's been really interesting. So yeah, I'm Angela Greenwood and I'm from the Violence Reduction Unit based at Chetcott Lane Police Station. And what that is a small home office unit. And what we try and do is reduce violence of all types while it's already happening, and then prevent it for the next generation where we can, across all types of violence. So one of the things I just wanted to make you aware, and Paul was very keen we did it today, is something really exciting is happening in Sheffield. And as you said earlier, Angela, you said you can't separate health from anything. And this is one of those projects in point because we've started trialling a safe space in Sheffield city centre. And that is during the night. So that's from 10 p.m. to 5 a.m. And it is a temporary set of 3 tents, and it's there to provide welfare, and it was originally to prevent violence against women and girls. So a few of us are members of the Violence Against Women and Girls Forum, and it's been talked about for over a year about having this safe space, have somewhere to go where you feel unsafe or you need some help. So it goes back to the city goals. I've been looking at the city goals while I've been sat at the back, so I've been busy. And it was about having this caring and safe Sheffield. And under one of those goals was, let's try new things out together. So we have done. We've tried it. We tried it during December. And then it's been that successful that we're still trying it out. And it's a number of partnerships, and many of you in this room are part of that. the Integrated Care Board, the Yorkshire Ambulance Service, the A&E Department, the Sheffield City Council, South Yorkshire Police, and then the charity sector as well, and the private businesses who run all the licensed premises. So it is as simple as what we say. Set of 3 tents, you can go in and you get triage because you've got a number of reasons. You feel unsafe, you feel you've lost your mates, you need your phone charging, but also you might have medical issues that you need some help with, or generally you feel that you need to talk to somebody. And in that tent, you get triaged, and you can either go into the medical side and get some medical assistance, or the welfare side and get a number of signposts or people are in there. And we've just been trying it. It's run by Licence Watch. There's a number of licensed premises that are running it, and now they've created their own community group since January. So they are Sheffield Safe Square, is the name of the community group. It's run by 2 ladies who are now front of house. We've took feedback on it, should be females at the front. But the most surprising thing for me is it's not just females using it. It's mainly 50-50, male and female users. But it's also the age range. We expected it to be 18 to 24s, but it's all ages are using it. But the thing I wanted to bring here, and if you do know me, I will talk for England, so please tell me when to stop.
I'll stop you soon.
Is the medical side, which we didn't really expect, and the savings and the help it's giving people. In December, for example, there was 105 people went through, I won't say the doors, the flappy doors, the tent doors, and of those, there was 64 were medical cases. And of those medical cases, because there's a paramedic in there as well as nurses, they stopped 50 of those 64 going to A&E. So they were able to stop them. And the Integrated Care Board have been really helpful. They've run it through their systems on, well, how much does that save in money terms? And just on December alone, they've said, if you take all the project costs out, it saves £16,000. And that's just December. That's the Yorkshire Ambulance Service, obviously, savings, and then being treated at A&E. But then it's the other savings we've been looking at. The street pastors are a charity that go round at night, if you've ever seen them, giving out flip-flops and hot water and cold water. But they can now pass on those people quite quickly and then get back to doing what they need to do. The police can do the same. They can take them down to the safe space and get back on patrol. So we're looking at the moment of all the different types of savings. And the feedback from the actual most important people here are the people using the space. It's been amazing, and so are the venues. They're really supportive. So my ask is really to be aware of it. If you want to see more about it, we've got more and more reports coming in. There's a very, very initial report now available, but I'd like to come back later in the year with Paul and tell you more about the impact it's having in our city centre and our nighttime economy, and the many, many benefits it's having, if that's all right, Chair.
Yeah, I would like to have you back, Angela. Yeah. Can we arrange for a time where, you know, if you let us know, liaise with Dan when a good time is for the report, and then we'll invite you back. Thank you, and thank you for all the work. And obviously, I'm on that violence against women and girls group, so I see you there. So thank you, Paul.
Just to add to that, Chair, is so the starting point was about violence and women and girls and giving that that safe place where people can go for advice. But in terms of overall violence reduction and protecting people within the nighttime economy, and I think moving to a more preventative place where collectively we're not just reacting to the symptoms, and we can invest effort collectively to save. I would like to invest in that approach. I think it's probably fair to say, Angela, that it's a very expensive resource at the moment when having to pay out for that. There's a lot of contribution from the private sector, for instance. In the interest of brevity, Angela's not mentioned that the hotel provides the electricity, the power and the water, all that sort of stuff, which helps. It is just tents, it's not a building, it's not a van. But I think if we are comfortable with what it does and can do for us, then the ability for us as agencies to come together to jointly invest, to save the ambulance run, to save the A&E admission, to save the fight, the person walking through the nighttime economy that feels more able to enjoy the night out and spend money in the economy. Just briefly, Angela, tell the story about the chap who...
I'm sorry, we don't have time for the story. We'll have the
So
story next time. Sorry, Angela.
Save it till next time.
Yeah. Douglas, did you want to...
Yeah, I just was going briefly because, of course, this happened in the ward I represent, and I think, anyway, we 3 ward councillors provided a contribution to the funding to make it happen, but I am keen to see another trial happen. I don't know if there's think, that's planned already, but if we could bring that back, because I mean the point is that it's clearly a good prevention measure, but I'm saying it's actually demonstrated the savings in costs to A&E and to the ambulance service, and be really good. I think it's important that actually the services that save the money front up the cost of running it, which is not huge, but it can't keep falling on the council to provide that.
Yeah, and just to answer your question, yes, the Central Local Area Committee put some funding in. It has been majority funding for the Violence Reduction Unit and the South Yorkshire Police, but we are, good news, I believe in it, a lot of people believe in it, and we're going to keep it running over the summer because we've got the Euros. We tried it in the busiest time of the year, which is December, which is either a good or a bad thing. So now you want to run it a bit longer just to see how it runs throughout the summer months.
Excellent, thank you so much. And Kate has got the last AOB.
Yeah, just in the spirit of parish notices, just a nice little bit of news has just come through. So the two relevant finalists for the MJ Awards, which are the sort of main awards for local authorities. The first one is in the category of a whole team approach to tackling health inequalities, so it felt important to flag it here. And that's the work on the sport and leisure strategy in particular, so using public health funding on green and open spaces. So that's a confirmed finalist for those awards. And then the other finalist is not here, but Alexis has been is one of only 4 finalists for Corporate Director of the Year. So in her absence, I just thought it would be nice to say well done to Alexis at this board.
Thank you. Yeah, very proud of that, and we just the nomination is quite an achievement. So that brings us to the end of the meeting. Next meeting is timetable for Thursday the 27th of June at 2 p.m. And it's going to be here. I just wanted to say thank you to all the members of the board over this municipal year, and all the officers, and in particular Dan, who's kept us on the straight and narrow and organised all the bits in the background. And so see you in June.